Hi, everyone. This is John Mandrola from the Heart.org Medscape Cardiology, and I'm here at the American College of Cardiology meeting, and I'm very happy to have my friend, Andrew Foy, who is an associate professor in medicine and public health sciences at Penn State, Milton S. Hershey Medical Center. And Andrew, welcome. Andrew has a paper today at the meeting in which he looks at multimorbidity in clinical trials. And the reason why I think this is important is one of the biggest things that we do in medicine is to try and take trial evidence and translate it to the person in front of us. And this paper looked at comorbidity burden. In other words, how much like our patient is the patients in the trials. And so, Andrew, tell us about the paper.
Yeah, sure. Thanks for having me. The trials that we looked at were ACCORD, which had basically three main studies, blood pressure, lipid, and glucose. I looked at the historical AFFIRM trial, which was rate versus rhythm control. We looked at the Berry 2D trial, which had really two studies within it, a revascularization trial and then a glycemia trial. We looked at SCUD-HEFT, which had two placebo comparisons, one with ICD and then another one with amiodarone. We looked at the SPRINT trial, and we looked at the TIMI 3B trial, which also had two studies within it. It had a invasive versus conservative management for acute coronary syndrome, and it also had a TPA. So those were the studies that we looked at. We had patient-level data from these studies, which we got from NHLBI BioLink data repository. So it was the individual patient-level data from the trials, and with that data, we classified patients based on their Charlson Comorbidity Index scores, and then we essentially redid the original analysis through the CCI-based subgroups and looked for evidence of treatment effect heterogeneity. I think the main takeaways from the analysis of all these studies is that, generally speaking, the patient populations of the trials tended to be fairly narrow in terms of comorbidity burden, which a lot of people might expect. One way we characterized that was by looking at the variance of the CCI scores around the median score of trial participants. It generally varied from about 1.5 to 3.25. But in general, most of the trials had a narrow population of patients. In general, the majority of patients had comorbidity scores of less than or equal to 4, which is about a 60-year-old patient with perhaps one major comorbidity or two. And then the last finding was that despite the narrow range of comorbidity burden within the trials, we still found treatment effect heterogeneity based on comorbidity score. And it was suggested in about 5 trials where we found p-values of less than 0.1 for interaction, and in 3 studies the p-value was less than 0.05. And then there was also some other treatment effect heterogeneity on a risk difference scale. And so, overall, we probably found about 8 total what we think are potentially important interactions.
Major cardiology trials that you got open data from enroll a narrow patient population, little variance, and tell us what exactly you mean by treatment effect heterogeneity, because in a typical paper we get the overall results and then we get these subgroups. So what exactly does treatment heterogeneity mean?
It means that the summary effect from the trial may differ significantly in a particular subgroup of patients. The way that's traditionally done in randomized clinical trials is this sort of kind of classic one variable at a time analysis, and oftentimes there's not a lot of real biologic plausibility to why treatment effect heterogeneity would occur based on the presence or absence of these individual variables. And it's really hard to, from like a holistic standpoint, apply that to patients who are more complex than having one variable or not. And so using a comorbidity score, I think, allows us to more holistically capture patient complexity, and you could make a case that it's better for finding treatment effect heterogeneity than the way that we classically typically do it.
Is the idea that a trial will give you an average result in an average patient?
It's the average patient in the trial, may not be the average patient in our clinic, but yes, that's the idea with the summary effect.
I've always thought, in my mind, that getting in a trial is kind of a special thing. You have to be a kind of special patient, and then you have special circumstances in the trial. And I've always wondered whether that um, uh, should be factored in applying the results to the patient, right?
Yeah, but one thing that's really challenging for clinicians is how do we really translate that? Because if you just look at how the trials are classically presented to us, with kind of table one that has the presence or absence of individual kind of characteristics, it's hard to say anything about what the actual average patient in the trial, who that particular average patient is. And so having a comorbidity score, again, I think it allows us to look at that in a more holistic way and have a better understanding.
Okay, let's talk about this Charlson Comorbidity Index and comorbidity burden. It's what exactly is it? Why is it important? And how is it different than just adding up a bunch of patient characteristics?
The Charlson Comorbidity Index, it's been around for a long time. It's probably the most highly validated comorbidity score. Um, it is a significant predictor of mortality, morbidity, hospitalization, and the predictive ability of this score has really withstood the test of time in a lot of ways. And even if you don't have all the variables of the score present, the relative weights of the individual covariates relative to one another retain their weight. So the score is quite flexible in that way.
You gave this lecture at the Kentucky ACC on comorbidity burden, and one of the disruptive things that I had always thought, and we kind of learned from the statin trials, is that the higher the average risk of the patient, the more likely that that relative risk reduction will result in an absolute risk reduction. So the sicker the patient, the more they're more likely to benefit. But some of the findings that you find are not that. It's like the opposite.
Right. And I think we sort of predicted that, but I don't think most people truly appreciate that. So a great example was the SCUD-HEF trial. So we know SCUD-HEF was one of the historic trials showing a benefit for ICDs for primary prevention of sudden cardiac death and of death in general. And you probably presume that the patients that were in that trial reflect the patients that you see generally in clinical care. But in the SCUD-HEF trial, we found a significant signal where it was actually patients in the first quartile of comorbidity score who had the most significant benefit. And for people out there, that score was 1 or less.
The healthiest patients.
And what that means is that this would have been a patient either 50 with they all had the comorbidity of having systolic heart failure. So this would have been a 40 patient in their 40s with no other risk factors other than cardiomyopathy. And also within SCUD-HEF, patients in the fourth quartile of the comorbidity score had no benefit whatsoever from the ICD. The hazard ratio was at 1.0. And those patients were 3 times more likely to die.
Tell us simply why that would be. Why would the youngest, healthiest patient stand to benefit from an intervention, whereas an older, higher risk patient who's more likely to have an adverse outcome, have the effect, sudden death, why wouldn't they benefit more?
It has to do with a consideration of all the domains that are involved in determining treatment effect heterogeneity. So those 4 domains are outcome risk, which is the outcomes that we'd be interested in. So for example, in SCUD-HEF, sudden cardiac death, right, and how that causes death in general. Then there's competing risk, which are events that occur and don't allow for the outcome of interest to occur. So that would just be death from other causes in a trial like SCUD-HEF. And then there's also treatment-related benefit and treatment-related harm. And I don't think for the purposes of SCUD-HEFT and for ICD, there's too much treatment-related harm. But even though patients in the highest quartile of CCI scores had the highest risk of dying and also the highest risk of dying from sudden cardiac death, they also had a lot higher risk of dying from other things as well. And the ICD can't do anything about that. Under those circumstances, the benefit of the ICD are washed out. And we should also keep in mind that in SCUD-HEFT in particular, that fourth quartile of patients was a CCI score of 5 or above. And I would argue that's probably the average patient who we put ICDs in practice.
And I'd also want to note that finding has actually there's been other papers on that, right? There's a paper by Fishbein et al. That looked at 6-minute walk test and showed that patients who were very poor on the 6-minute walk test didn't benefit. What are the implications for this kind of work looking at comorbidity index from these trials?
First off, it lends credence to the idea that we may have issues with external validity of our contemporary clinical trials. The notion that these results may not be representative for the patients that we think they're representative for. I think that's the first thing. Two, I think it shows that comorbidity matters and it has an interaction with treatment effect. And because patients with higher comorbidity tend to be excluded from clinical trials, we need to be very careful about just assuming that they also benefit from things that we find to be useful in contemporary clinical trials. I think the third is that maybe trying to more systematically capture these variables would be a really huge benefit to the evidence-based medicine community and just people and just physicians in general who are trying to clinically translate results from RCTs. Trial funding comes from many places and a lot of independent bodies, but if there could be some sort of general consensus around what variables are going to always be collected so we can always sort of assess this, I think that would be a massive benefit to the field.
Well, excellent. Thanks for coming on. I really appreciate it.